I'll be presenting on ataxic dysarthria. Ataxic dysarthria is associated with damage to the cerebellar control circuit that can be caused by neurologic injury, disease, or disorder. This presentation aims to address how the effects on cerebellar control circuit can cause communication and swallowing impairments, and how, as speech-language pathologists, we might address these issues. Individuals with ataxic dysarthria present with respiration, phonation, resonance, and articulation issues that ultimately affect their motor, speech, and swallowing mechanisms. What is ataxic dysarthria? Ataxic dysarthria is a sensory motor speech disorder associated with damage to the cerebellum or its input and output pathways. Traditionally, ataxic dysarthria has been characterized as a disorder of motor execution with focus on the uncoordinated and hypotonic muscles. Ataxic dysarthria appears to be universally recognized. It was first described as scanning speech in 1877. Overall, ataxic dysarthria affects timing and coordination of muscle movements. Ataxic dysarthria can occur due to vascular lesions caused by aneurysms, arteriovenous malformations, or hemorrhage that occurs in the brainstem or midstream. It can also occur by tumors. One example is acoustic neuromas. These are benign tumors that develop on the vestibular nerve or the auditory nerve, affecting balance and hearing. They lead from the inner ear to the brain. Trauma to the cerebellum may also lead to ataxic dysarthria. Degenerative diseases such as multiple sclerosis and Friedreich's ataxia may also have ataxic dysarthria. Toxic and metabolic diseases, as well as hypothyroidism and normal pressure hydrocephalus, can also lead to ataxic dysarthria. Ataxic dysarthria is an article conducted in 2000 with a sample size of 14 individuals, 7 males and 7 females with ataxic dysarthria. The study performed several speech tasks, which included sustained vowel phonation, syllable repetition, sentence recitation, and conversation. The results of this study showed that during the sustained phonation section, the largest and most frequent abnormalities for both men and women were in fluctuations of fundamental frequency. When assessing syllable alternating motor rate, all the subjects with ataxic dysarthria were both slow and variable compared to normal speakers. During the sustained phonation task, women showed more abnormal values of jitter. In conclusion, the article found that ataxic dysarthria reflects a global impairment, respiration, laryngeal, and articulatory subsystems of speech. There is at least a subtle difference between males and females with ataxic dysarthria. In 2007, a study was conducted designed to collect and analyze information regarding swallowing disorders in dysarthria speakers after the onset of a variety of neuromuscular diseases. It focuses on a systematic approach for determining the relationship between speech and swallowing dysfunctions based on the type of dysarthria that may be beneficial in the clinical management of these individuals. The study contained 113 individuals with dysarthria, 79 men and 34 females. The age range was about 60 years old. The results demonstrated a high correlation between swallowing function in every level of intelligibility, regardless of the primary etiology. This shows the management of dysarthria should not only include speech interventions, but should also have dysphagia interventions. However, these results showed that when dealing with ataxic dysarthria patients, it rarely produces severe dysphagia. Some clinical implications of this study. When dealing with the structures and functions, it is important to keep in mind that the incoordination of motor movements and weak muscles leads to the communication and swallowing issues found in ataxic dysarthria. Inconsistent velopharyngeal closure is often common in those with ataxic dysarthria. Slow tongue movements with a reduced range and velocity may also occur. Due to the weak and uncoordinated respiratory muscles, poor breath support, diminished cough, abnormal respiration cycle, and decreased closure of the vocal folds can be found with these individuals. When observing neuromuscular defects, these individuals will have difficulty standing and or walking, as they will present with a wide gait and truncal instability. They may have tremors. Nystagmus eye movements may be observed by these individuals. Dysmetria is common. Dysmetria is a disturbance in the trajectory of a moving body part or inability to control movement range. Dysdiadochokinesia is also shown and can be observed during athero-OPE. Errors in timing and speed of muscles in patients with ataxic dysarthria will result in poor coordination. Their movements tend to be conducted at slow rates of speed. Facial weakness may also be presented. Ataxic dysarthria is characterized as an impairment of articulation and prosody. It is often described as drunken or slurred speech. Characteristics of individuals with ataxic dysarthria will have equal stress on both syllables and words when speaking. They will have irregular articulatory breakdowns. Vowel distortions are very common, and their speech will often be very slow. They will also have issues alternating pitch and loudness. Their vocal quality will appear hoarse, weak, breathy, or unstable, and they will show issues with syllable alternating motion rates. Swallowing issues mainly occur during volitional movements in the oral phase of swallowing. They will express diminished mastication due to weak and uncoordinated muscles. They may have nasal regurgitation and diminished cough. They will show abnormal respiration cycle during swallowing due to the weak muscles of respiration. Therefore, assessing and managing diet levels to prevent aspiration is vital in these patients. Due to lingual control being affected and weakness of muscles in patients with ataxic dysarthria, the following characteristics are also common: oral stasis, incoordination of the bolus, difficulty initiating swallows, premature spillage, impaired bolus transit, incoordination between lingual and pharyngeal structures, and penetration or aspiration. When obtaining diagnostic information, it is important to perform a thorough chart review. Looking at the history and physical, we also want to get a picture of the type of onset and how has this patient status changed since the last time we've seen them. Looking at imaging is vital because we want to know where the lesion is. Is it cerebellar? We want to talk to the nurse to get a better idea of who our client is and how they present today. We also want to understand the patient support system and who they are going home to. The OPE is going to be extremely important when assessing these patients. We want to assess their DDK rates to judge speed and regularity of jaw, lip, and tongue movements that are needed for articulatory precision. We want to look at the level of muscle tone this client has. We also want to assess vowel prolongation to determine if respiratory support for phonation is adequate. We want to get a good idea of which cranial nerves may be affected, and we also want to look at their ability to change their pitch. Treatment selections depend on a number of factors, including the severity of the disorder, natural history and prognosis of the underlying neurologic disorder, the perceptual characteristics of the individual's speech, and his or her communication needs, patient and family preference and engagement, and the presence and severity of co-occurring conditions. The goal of intervention is to help the individual achieve the highest level of independent function for participation in daily living. For individuals with dysarthria, treatment focuses on facilitating the efficiency, effectiveness, and naturalness of communication. In acute care, we want to prepare the patient for the next level of care and provide valuable information for the next speech pathologist. Treatment can either be restorative or compensatory, depending on the client factors presented. Communication strategies may be used to enhance communication when intelligibility is low. These include teaching the patient signs that their communication partner has not understood the message and using conversational repair strategies to try again. Also, to use more gestures and pointing to help them convey their meaning. Environmental modifications can also be made to enhance comprehensibility for the listeners. This can be done by reducing background noise and improving proximity between speakers. AAC may also be used when intelligibility is low. Treatment should target speech production subsystems such as respiration, phonation, articulation, resonance, and prosody. When targeting respiration, we want to make postural adjustments for adequate breath support for speech. Using controlled exhalation tasks that involve taking in air slowly over time to improve controlled exhalation of air for speech. When treating phonation issues, We want to maybe use LSVT to help control and increase loudness and improve intelligibility. We may also use pitch limiting voice treatment to increase loudness without increasing pitch. Articulatory therapy can use phonetic placement techniques to work on positioning the mouth, tongue, lips, and jaw during speech production. We may also use over-articulation and rate modification strategies. Paddle lifts prosthesis may also be in place when we're dealing with residents. To help with prostate issues, we want to increase their awareness. Overall, ataxic dysarthria can be characterized by vascular lesions, diseases, and injuries that can have lasting effects on individuals. As speech pathologists, it is important to understand the role of the cerebellum as it relates to the coordination of different muscles responsible for speech and swallowing. It is important to complete a case history, including a thorough OPE and perceptual assessment. When it comes to therapy, it is important to keep in mind what the patient presents with and how to address those impairments to improve intelligibility based on the ICF model. The following are references for this presentation.